An issue that's come up over the last couple of days is the issue of dual maintenance for HIV. And we're delighted to have two wonderful speakers, and we're going to actually have a debate. And the title the OC decided on is Dual Maintenance for HIV. Why fix it if it's not broken? Next slide, please. So we have two spectacular speakers here, both who have been dedicating, I think, more than 2 decades to figuring out how best to use the drugs we have. So we're very fortunate to have both Jose Arribas from Madrid and Andrew Hill from Liverpool. Jose will take the pro perspective and Andrew the con perspective. And I'd like to, a special thank you. People always say it's a good idea to have a pro-con debate, but no one agrees to do it. So I think it's really nice that both Jose and Andrew are courageous, and we appreciate it. So the format, next slide, please. So this is the format. We're going to have Jose give a short slide presentation of 12 minutes with the pro perspective. Then Andrew will get up and do the same for the con, and then they'll both be on stage for clarifying questions. But this is not meant to be the debate, but if they show data which folks would like to ask questions about specifically, this will be a good time for specific questions on the presentation, not necessarily the issue. Then we'll allow Jose a few minutes for a rebuttal, and Andrew the same. And after we've gone back and forth, we'll have everyone on stage and open up for everyone here to give their opinion on this issue. So with that, Jose, you're up.
So, and it's a pleasure to talk about one of the remaining issues in antiretroviral therapies is dual maintenance therapy versus triple therapy. These are my disclosures, conveniently divided by companies that have used only triple, triple and dual, or triple, dual and mono. You see the asterisk, because that means the asterisk is not there, it means so far. The only triple so far. MSD is already doing a phase 2 trial of MK-8591 and doravirine. So, if you want to convince the FDA that you have a combination that should be approved for treatment of HIV infection, you read this is the guidance for the industry, and they say that the goal of antiretroviral therapy is to maintain HIV viral load undetectable. Please note that doesn't say anything about the number of drugs, doesn't say anything about persistent inflammation, doesn't say anything about efficacy in semen. What they care about is to maintain plasma levels of HIV RNA below detection. So the critical question is, do we need 3 antiretrovirals to achieve this goal? So this is just a very comprehensive slide looking at the decrease in viral load short-term with different families of antiretrovirals. And what I want you to realize is that we are in the era of integrase inhibitors, all those blue columns, and you can see that those blue columns show that there is a lot of potency, a lot of efficacy, and they compare very advantageously compared with other families of drugs. So we have very potent integrase inhibitors right now at our disposal. The other issue is that we have also very resilient drugs against resistance development. This is from a publication looking at the risk of resistance development with different types of antiretrovirals. You can see there that with boosted PIs, the risk of becoming, in the context of clinical trials, of becoming resistant to the boosted PI is almost 0. A few patients have resistance to nucleosides, but if you look on the left, if you look to dolutegravir, and bictegravir could be there also exactly the same. This is an old paper, so bictegravir is not there. You see 2 zeros because there is no development of resistance in clinical trials of these highly potent, high genetic barrier integrase inhibitors, bictegravir and dolutegravir. So in 2019, we have a family of drugs that have very high potency and they have a high genetic barrier to resistance. And when this question has been put to test in a randomized clinical trial, the Gemini trial, you see here proportion of participants undetectable by week, less than 50, And the legend is there, the legend of what is what is orange and what is blue, but you can get away without the legend because who cares what is red and what is blue? The two curves couldn't be more overlapping. It's actually very difficult to tease out in these two lines what's the effect of the second nucleoside. This is the comparison of TDFFTC, dolutegravir versus dolutegravir 3TC. And if I had to think up front where there was going to be a difference, probably will be in the speed of response. But you can see here that at week 8, the proportion of participants undetectable is exactly the same in the dual therapy arm than the triple therapy arm, provided that this is limited to participants with at baseline less than 500,000 copies per ml. Actually, if we look at time to undetectability, it's true that participants with higher viral loads, you see there on the right, and that participants with viral loads above 100,000 copies per ml took longer to achieve undetectability, but you can see, again, no difference between 2 drugs and 3 drugs. And finally, we have recently this data presented at CROI using this trick that actually Andrew Hill and myself, we did that in Monet. I remember the study of monotherapy. When you order a PCR test for HIV, you can have a result as undetectable, but within the undetectable, you can have target detected and target not detected. And we know that that has a biological meaning. When you have target not detected, it's more difficult to detect residual HIV replication by single copy assays than when you have a result of target detected. And this is by intention to treat, but you can see also that throughout the trial, proportion of participants who were target not detected, saying other way is with residual replication between below 40 copies, was exactly the same in both arms. So I think this trial provides an important base for the notion that you can really, in 2019, suppress viral replication with 2 drugs. The other important study, and I really against talking about 2DR in general. That's saying nothing. 2DR is like telling your resident, give this patient triple therapy. But what triple therapy? It's very important. So with dual therapy, we have to be really specific. And I've shown you data with dolutegravir 3TC. This is from the SWORD trial. This is a maintenance study. Participants suppressed on triple therapy with either of the 3 families, non-nucleosides, integrase inhibitors, or PIs, randomized to continue or to switch to dolutegravir rilpivirine. The trial was the first time that nucleoside sparing and ritonavir booster sparing regimen met the efficacy of triple therapy. And that allowed for the first time approval of this dual combination for maintenance. Another combination, dolutegravir rilpivirine, that has shown efficacy. And I've worked also in these trials of boosted PI plus 3TC in the realm of participants treated also with triple therapy with a boosted PI. When we compare continuation of triple therapy, 2 nucleosides and a boosted PI, or switching to a boosted PI plus 3TC, these trials were relatively small. None of them could meet the criteria of the ADA for switch studies of a 4% non-inferiority margin. But with this individual patient data meta-analysis, and when you add all these trials, you have more than 1,000 participants. And you can see there that the studies prove the non-inferiority of the dual combination of a boosted PI plus 3TC versus a boosted PI and 2 nucleosides, and the confidence interval is within the 4% efficacy margin. And also we've seen at CROI this year, for the first time, type of parenteral art, long-acting with cabotegravir and rilpivirine, 2 different studies of maintenance with this combination that is double with cabotegravir long-acting and rilpivirine long-acting compared to triple therapy. We've seen that non-inferiority was met in both trials. So again, with two drugs, in this case, cabotegravir, long-acting, and rilpivirine. So why fix it if it's not broken? Well, if you look at the AX guidelines and they tell you why to switch, is because of documented toxicity, prevention of long-term toxicity, aging and comorbidities. I have highlighted these issues as type of proactive switch. And imagine you have a patient doing well on abacavir, 3TC, dolutegravir, or TDFFTC, darunavir, cobicistat. Why fix if it's not broken? Well, because you can avoid adverse events. If you look at here at the EACS guidelines, again, at the toxicity of abacavir and TDF, you will see cardiovascular toxicity with abacavir, with TDF, the well-known bone and renal adverse events. So you can switch these patients, provided with the data I've shown you so far. It's not switch, it's just to drop one of the drugs from abacavir, 3TC, dolutegravir going to dolutegravir, 3TC, or drop TDFFTC going to 3TC, always remembering that you have to check the patient is hepatitis B immune. The thing is more complicated if you are taking TAF-FTC dolutegravir or TAF-FTC darunavir cobicistat. What are you going to avoid? Well, if you look at EACS, if you look at TAF, TAF is a very safe nucleoside, and actually you can't avoid anything because there is no particular toxicity with TAF. My argument here, to be provocative, is because you are using more drugs than needed, and you don't do that for other infections. You don't use the antibiotics if one is enough. You don't use 3 hypertensives if 2 are enough, and you don't use 3 lipid-lowering drugs if 2 are enough, and also because it's cheaper. So you can make the point that you can switch these 2 regimens, first one to dolutegravir 3TC and the second to darunavir 3TC, provided, again, that the patient is hepatitis B immune. So I made my argument for virologic control. I think you can make a strong argument for virologic control, but there is another issues that regulatory agencies do not care about, and for the sake of debate, I call it less than 3 phobia, is saying because you are dropping one nucleoside, you are increasing inflammation, or you are increasing reservoirs, or even that if you are undetectable with less than 3, that might not mean untransmissible. And also you are against almost 20 years of antiretroviral therapy with 3 drugs. So just a couple of slides to show that when we have looked at these biomarkers of inflammation in SWORD and compared dual therapy with triple therapy, there is really, during the randomized part of SWORD, no difference in these biomarkers of inflammation between dual and triple. When we look at proviral DNA, also other investigators in the lamidol study switched to dolutegravir 3TC. Again, no signal of an increase in proviral DNA. So I'm going to close my argument saying that triple antiretroviral therapy commandment is a legacy of an era of less potent drugs with lower genetic barrier to resistance. There is a strong evidence that the goal antiretroviral therapy can be achieved with some very specific dual combinations, dolutegravir 3TC, naive and maintenance, dolutegravir rilpivirine, darunavir 3TC, or cabotegravir rilpivirine long-acting. Benefits. Well, I did not completely agree that I have to show the benefits. I will leave to Andrew to tell me what is the benefit of adding the 3rd drug to this, or avoid unknown adverse events, and also to decrease the cost of antiretroviral therapy. So I'm going to wait until it clicks 0. Thank you.